All right, well, as you can see, Greg Davis, a long-term colleague and friend, I think for years has been giving us a presentation regularly. This is just a preview of his involvement in the Northwest Allergy Forum. I'll just mention it now. So October 5 and 6, we have the Northwest Allergy Forum here in Seattle. And Greg's going to be giving 2 presentations. So definitely sign up for that event. But today he's going to talk about rhinitis, as you can see, an evolution in treatment options. I don't have too much else to say, except thank you for coming in person and setting and doing this for us.
Well, thanks for the invitation. I think this group is amazing. The fact that you all get together either online or in person once a week is inspiring, and I wish our group did it. So thanks again. I enjoy giving talks here. I enjoy listening to the lectures as well. Unfortunately, Tuesday is now my OR day, so I can't always join up. But I am going to talk about rhinitis, and it's kind of strange because why is a sinus surgeon talking about runny noses? Like, really, is that the best I have for you? But I think it's important because my goal when I give lectures or discussions, I hope this is more of a discussion than a lecture, so please interrupt, is to kind of bridge the gap and find something that I'm doing that I think will help you and your patients today, tomorrow, the next day, as opposed to just send me your sinus surgery patients. I really hope this is collaborative, and my sharing of patients with colleagues like Glenn and many of you have been wonderful. So a couple disclosures, nothing at all that relates to this talk. My practice started at the University of Washington after a fellowship in Adelaide. I'm a rhinologist, so a sinus subspecialist. And I was at the UW for 13 years and then figured I had about 18, 19 years of eligibility left. So like many Huskies around this time, I entered the transfer portal and moved 33 miles away, which is 3 miles outside my draconian non-compete, to this wonderful clinic down in Puyallup, Washington. And I did it really just to get out of my non-compete for 2 years, but I love it. It's amazing. It's so refreshing to have a clinic where I have my own nurse. So it's a group of 5 of us. And 5 ENTs. I have my own. We all have our own nurses. We all have our own medical assistants. Patients actually get called back the same day. I know, amazing. So right there, that's like a game stopper. But we also have our own surgery center, which is such a fantastic way of doing routine and complex sinus surgery in an ambulatory surgery center where patients don't have to go through the whole hospital network. They don't have to go to the hospital for a pre-op visit and then come back for their surgery. It's very nice and contained. So I've enjoyed it immensely, and I have no intention of leaving at this point in time. It's not too far from here, so a lot of my patients have been able to drive. I'm still academic though, so even though I left the University of Washington physically, I'm still a clinical associate professor. I have 5 clinical trials going on right now. The first one I just want to mention to you is a randomized trial looking at post-viral smell loss, specifically post-COVID smell loss, but it can be any coronavirus or adenovirus can cause smell loss. And patients just need to have hyposmia, so partial smell loss between 18 and 65 years of age, and symptoms onset within the last 2 years. So if any of these patients walk into your door, just send me an email with their contact information and we can take care of the rest. And it's using a drug called theophylline, which many of you remember, probably haven't used for some years, but in a nasal spray form. And in a nasal spray form, the pilot study was promising. It doesn't have the side effects that the oral version of theophylline have. And it's only a 3-month study. All right, so moving on.
Before you do, how do you assess the smell loss?
The smell loss is assessed by a complex testing called the sniffing sticks. It takes about an hour and a half. It's the best validated way to measure smell loss. So it measures not only smell identification, but threshold sensitivity. So think of it kind of like a hearing test. You know, a hearing test, they present you a sound and then they lower the decibels or raise the decibels. That's the threshold. So you can do that with smell as well. You present a concentration, and if they can smell it, then you go lower on the concentration. You keep going lower and lower until you get that threshold. It's a nice way to measure if they're getting better. The whole study, then they have to get an EKG, they got to get blood draw, urine. It's quite a process. But I have a wonderful research nurse who.
I guess while I'm interrupting you, and why did anybody think Teophylline would help that?
It is, it's a non-selective PDE inhibitor, and that helps with the calcium gate that is critical for the olfactory sensory neuron to propagate the signaling. So if you get a little bit of a signal, it'll keep the calcium open and that neuron will keep firing. That's the thought. And actually, in an oral form of the study, it worked. It wasn't a randomized trial. It was actually my R01 that didn't get funded. So I never did the randomized trial and hence left the UW. But yeah, had it got funded, I might still have a badge like yours.
It doesn't it also block the adenosine receptor?
Maybe.
I know in the lung it does. I don't know about whether it's relevant in the nose.
Yeah, not sure on that. Okay, so we're going to talk about rhinitis and why a sinus surgeon's talking about runny noses, the sniffles. And then I want to just try to bring in some discussion. Hopefully we have time about biologics and the role for sinus surgery and the timing of sinus surgery, because this is where I think discussion is really important. We don't have the research studies to actually support what we all think. We know biologics work, but how do they work the best? All right, so this video, oh good, you can hear it. So, why do we talk about rhinitis? It's because it impacts quality of life. Like how many of our patients come in and say, oh, I have the sniffles, my nose is always running, or the drainage is always going down the back of my nose. I know it's hard. Yeah, I know this guy. And or people walk in, they have Kleenex tucked in their sleeve or down their bras, and I do the laundry in my household, and I'm constantly, or I used to be constantly, fishing out Kleenex from the dryer. So it's important because it affects a lot of patients, and there's a very several different versions of rhinitis that we need to go over first before we can actually figure out how to treat it. So knowing what you're treating first before just throwing medicines at it is, I think, important. So there's allergic rhinitis, infectious rhinitis, which is basically infectious sinus disease, and then non-allergic, non-infectious rhinitis, everything else. What does that mean? There's drug-induced, NSAIDs, PDE5 inhibitors, antihypertensives. Those can cause a drug-induced rhinitis. Hormone-induced rhinitis is an entity. Elderly rhinitis. Why is there a hypercholinergic state as we get older? Nearly everybody over age 65 has a version of rhinitis. Gustatory rhinitis, it's very common when you eat a nice hot spicy Thai meal. And then occupational rhinitis, irritants, and that can be any of the chemicals, but also the things, not just occupational, but I would expand that out to things like forest fire smoke, things that cause your patients to have worsening asthma. It's also causing inflammation in the sinuses. They're not allergic to forest fire smoke, right? It's just the particle size that's the irritant. Atrophic rhinitis is a dry, crusty, painful nose. And then finally, vasomotor rhinitis, which is 71% of all types of rhinitis. And I like to explain that more with a case scenario. So this is a typical patient. And it's interesting now that we as within ENT are treating rhinitis, we see more of these patients. A lot of them come from allergists or pulmonologists. So this patient, 72-year-old female, this is not her, this is just a Google image, but kind of looks like her. She was complaining of post-nasal drainage and no sinus pain or pressure whatsoever, no nasal congestion, but post-nasal drainage was worse with exercise and eating. And she had already been on fluticasone and azolastine spray. By the way, how many have used azolastine or Astapro? Is that just amazing stuff or what? Who thinks it's amazing? Well,
Except for tasting bad.
Except for taste, yeah, but during this tree pollen season, yeah, lights out. Drew Ayers just texted me. Drew, I don't know if you're watching now or not, but he was my allergist. I did 4.5 years of allergy shots with him. And tell patients, one of the top 20 decisions I've ever made. Scout's honor. True story. Anyway, I digress. So azolastine works great for allergies. Doesn't do much for non-allergic rhinitis. Skin allergy testing was negative or mild. What do you do next? What would you do? Anyway, shout out, what would you do as the next step in treatment?
Ipratropium.
How many would do ipratropium?
You don't like it.
That's a great answer.
Too dry?
Dr. Alter.
It's approved for it.
Yeah.
Yeah, so that's, and it's actually one of our board questions. It's an easy board question, but yeah, it's one of the board questions. So it just shows you that our world in ENT is starting to say, yeah, you guys can actually treat this, just a little spray. So ipratropium, 1 to 2 sprays once or twice a day. True story, my wife had really exercise-induced rhinitis. Every time she hiked, walked the dog, she would get a runny nose. I did this, prescribed it for, oh wait, I'm saying this out loud. Prescribed it for my wife. And just as a trial, right? Emergency situation. And she's, wow, this is amazing. You're really smart. I'm like, I don't know, not really, but. So what I do a little bit differently. Patients come in with this, I'm gonna do a nasal endoscopy. It's really easy. It takes 45 seconds. We spray the nose with some Afrin and lidocaine, so it tickles out. If it's done properly, it tickles, maybe a little bit of pressure, but it's not painful. Now, if you have a resident do it, that's a different story and they're learning and kind of bump off the sides, but that's part of learning. And we're looking for signs of chronic sinus disease, inflammation, swelling, polyps, purulent drainage. Assuming we don't do that, we're gonna do ipratropium. And then I have them return to clinic, plan to have a sinus CT scan if their symptoms are not better. And that part of that is because I was involved with 3 clinical trials that we're going to get to, part of it using a device to treat post-nasal drainage. And part of the protocol was to do a sinus CT scan, basically looking for a cold sinus disease. And a lot of times, most of the time, actually 80% of the time, you see healthy sinuses, but 20% of the time you see this. Patients don't have, and so this is a opacified sphenoid sinus here, both sides, right side, left side, versus nice, healthy sphenoid sinuses. And these patients don't complain of vertex headaches or post retroorbital headaches like a lot of patients with sphenoid disease do. Some patients with sphenoid sinus disease will complain of V2 pain or pressure, so right here in the cheeks. But many times they don't have any complaints. And this is just long standing. You can tell it's long standing because the bone is thickened. This is the inner sinus septum. See how it's nice and thick here versus the thin bone over here. So that's what bone does when it's exposed to chronic infection or inflammation. It kind of builds a callus. And so this, if you treat them with the treatments for postnasal drainage that we're going to talk about, it's not going to work. You have to treat their sinus disease. And just as a quick side note about sphenoid sinus disease like this, when it is completely opacified or nearly opacified, the challenge is these patients come in, their only symptom is postnasal drainage, right? They don't have the classic sphenoid sinus symptoms. And so how do you know this gets better? And in our world, it has to get better because of the link and the porous nature of the cavernous sinus, which sits right next to the sphenoid sinus. So there's direct communication between the sphenoid and the brain. And so we need the sphenoid sinus to get better. So if the patient's not having symptoms, I'm going to treat them medically after this scan. And then I am the one situation where I'm going to repeat the CT scan because I want to see that sinus improve. Even if it gets a fair amount of air in it, that's okay. We need egress of bad stuff out and good stuff like air and saltwater irrigation's going in. So you got to get that sphenoid better. All right, now let's talk about why are they getting this postnasal drainage. I would backtrack 10 years ago. We all thought this was related to gastric reflux, right? That was based off a small randomized trial that showed if you give a patient with postnasal drainage a PPI, their postnasal drainage gets better. And that's true in a small percentage of patients, like 30%. And we didn't do anything until we found a new tool where we could actually treat this, and that's not ipratropium. But what we have is this postganglionic parasympathetic fiber that's coming out of the pterygopalatine ganglion or off the pterygopalatine ganglion. It's sitting here in the back of the nose, and it supplies basically the mucus glands of the nasal cavity. And we used to think it was coming out of one foramen. And so what we would do if patients had altering, horrible quality of life, we would do what's called a Vidian neurectomy. It's where you would go in and essentially do a sphenoid sinus surgery, drill down until you get exposure to the Vidian nerve, which sends a branch down to the sphenopalatine ganglion, but also, unfortunately, it sends a branch up to the lacrimal gland. And you would cauterize it, you bipolar it, and you would go through the mouth back in 76, and you would go through the lip, and then finally endoscopically. But the problem is the dry eye, because you would take that nerve before the branch up to the lacrimal gland. So I probably, in my 13 years at the UW, did this surgery maybe 4 times. And patients just had to be absolutely miserable. Usually they would be so miserable, I would rule out a CSF leak prior to doing this, probably always. But it worked about 50–60% of the time. And then posterior nasal nerve ablation came out about 2017. This was the first device. And I presented this to this group in a short version back in 2019. I was looking through my old slides. And this is the first one called Clarifix. It uses cold therapy to treat postnasal drainage. And this study came out around, let's see, what was it, 2017, 26 whole patients, and it showed a significant improvement in the TNSS. So pre-op was 6.2, the 12-month post-op TNS was 1.9. So improvement in the nasal drainage, rhinitis, itchy, and nasal congestion. And it's an easy procedure to do in clinic. Very easy. This is just a quick look at what it is. You put it in. This is up here is the middle turbinate. This is the septum, so patient's right side. And this little balloon that inflates with nitrous gas, it cools it instantly. And essentially it's freezing the tissue. And somewhere where it freezes, about probably a nickel size, somewhere in there is a nerve or the branches of the posterior nasal nerve. And then you have the patient breathe through the nose and you wiggle it off, and that's what it looks like. You see this white traumatized area of the tissue. If you numb up the nose correctly, patients don't feel hardly anything during this procedure. However, about 10 to 15 minutes later, 40% of patients get this horrific ice cream headache, and it just feels like the most intense pressure in the middle of their head, in their teeth. And I remember, I'll never forget, the first time I did this procedure at the UW, about 2017, 2018, I had 3 patients lined up. The first patient was a varsity track player, and she was tough as nails. Like, she's going to be outstanding. And I did this, and she did great, didn't feel anything during the procedure. 15 minutes later, she was in tears for 2 hours in my clinic crying. And I had 2 more patients to do after this. I'm like, this is silly, I'm done. Fortunately, the next 2 went great and had no ice cream headache. So it also only treats that one source. And so a company then changed and went to a radiofrequency treatment. This is low temperature heat, 60 degrees Celsius. So it doesn't burn, it's not cautery. Cautery is 400 degrees Celsius. This is quite a bit less. It doesn't produce aerosols, so we could actually do this during COVID. I guess we're still during COVID, but it heats the tissue. And essentially where the nerve area is, it destroys that nerve. That's what we're shooting for. And just like the other study with Clarifix, it showed a significant decrease in rhinitis, itchy congestion. So 58% reduction in the overall score and 81% responder rate, which is great. This is a picture of a 48-year-old female, no congestion, vasomotor rhinitis with exercise, and she prefers to avoid sprays. And this is what it looks like using this little device, and that's it. That's as exciting as it gets. So this is in clinic, and there's no smoke, there's no burning. It's just you sit there and the machine beeps at you and you go through it and they go about their way. It works, but could it work better? And what we found, this is from my mentor, PJ Wormald in Adelaide, is that there's a lot of little areas where the posterior nasal nerve branches out. It's not just the one nerve like Netter drew or Gray drew in their anatomy books. And all these nerves branch out, which is why if you just target 1 or 2 little tiny areas, it doesn't work in everybody. The success rate, again, about 80% responder rate. So 1 out of 5 people, it's not working. A friend of mine, Mas Takashima, did a study on 31 patients who had posterior nasal nerve ablation, that's PNNA, and they looked at where the middle turbinate attaches. And if the middle turbinate, which is this So, yeah, which is this structure right here. If that attaches posteriorly behind this phenopalatine foramen, then those patients had success. If the middle turbinate, like this one here, attaches anteriorly to the foramen, well, that's where the device goes in. So the device is not really getting that posterior foramen. And they found a significant, that predicted success. And that's why 35% of the Clarifix and Rhinitis patients in their study did not respond. So a company picked up on this and said, well, what can we do to improve that? And then this company created this device that has all these little leaflets, I call them butterfly wings, and each of these little nodes delivers the energy. It's bipolar, so it delivers the energy between these two leaflets. And so on each side, instead of 1 or 2 spots, it's delivering these 20 little micro lesions and much less energy, which is important because there is a 1% risk of significant bleeding with this procedure. And the significant bleed with any of these devices happens on average 3 weeks afterwards. So what's probably happening is that there's probably some little pseudoaneurysm that forms because not only is there a posterior nasal nerve, there's also a posterior nasal artery. And that's a decent sized artery that we use for, that goes to the septum. We use it to reconstruct CSF leaks and things like that. So the thought was this is hopefully safer, and the research has shown that it's safer than the other versions, which is why I switched to this version. It's pretty easy. Here's a quick video of what it looks like. This is on a patient wide awake in my clinic, and you open it up and it has these little leaflets that deploy. It kind of hugs. This is the middle turbinate right here. And it knows that I'm on the patient's right side, so it's only going to deliver energy to the proper side, not the septum side. It takes me about 15 minutes to numb up the nose. I use tetracaine gel. I just squirt the gel in the nose and walk away for 15 minutes. No injections. Patients come back, their nose is numb, their teeth is numb, they blow out the tetracaine, and then I do the procedure. The average pain levels are 1 out of 10. So again, the art of it is not actually the procedure, it's numbing up the nose in a nice, friendly way so that patients give you a 5-star Google rating. That's so important these days. Who follows their Google rating? The providers. Come on. Yeah. All right. So this is the study on this one, and 36 patients, so 10 more than the other one. Same outcome measure, the TNSS, no adverse events, 53% improvement in rhinorrhea, 55% improvement in nasal congestion. And this is just the overall score. So again, the take home is all 3 of these techniques work. The Clarifix, which is kind of, it's a general term, that's the cryotherapy. It's a general term like Q-tip, right? Q-tip or Kleenex, those are name brands. And a lot of people will refer patients to me to have Clarifix done. I'm never, ever in my life going to use Clarifix again. It's not worth the ice cream headache. So just so you know, if you do send someone to me or any of the rhinologists who do this, they're likely going to get something other than Clarifix.
Are any of these studies controlled where you put the device in, but you don't activate it?
Yes, so this one is not the randomized trial. There's an ongoing randomized trial that I probably can't talk about, but it's showing very positive outcomes. Yeah, but most of them are not randomized trials. And again, there's one that will be published probably in the next 6 months.
And so it looks like there's sort of equivalent magnitude of efficacy for each of those outcomes within the TNSS. And I thought that like allergic rhinitis is a systemic disease that comes, the cytokines are circulating and there's recruiting inflammatory cells, but so they also require the nerve input, because it seems to me that or at least maybe I'm outdated in the basic science here, but I thought that the nervous input may be more relevant for sneezing and perhaps rhinorrhea than congestion, for example.
Yeah, I agree, and I think the same way. Really interesting thing is and I didn't get into this in these studies, but all the studies dichotomize allergic versus non-allergic rhinitis, and they say it had the same amount of responder rate. Which doesn't make sense, right? If an allergic is a histamine response, why is blasting the postganglionic parasympathetic nerve doing anything. And so for a while, I was actually thinking, well, are we just zapping the sensory nerves back there and they're not sensing the postnasal drainage anymore? It was a thought. Now, trust me, when you put the endoscope back there, patients still feel it. So I don't think that's exactly it.
And the data, especially if they're controlled, so.
Yeah. But it is something now that is in our armamentarium, and it's relatively easy to do in the right hands, and it does help people significantly. Like, it's first time I did the RF treatment. So not the Clarifix, but the RF treatment, I did it on my medical assistant's wife, and she's a straight shooter. And I knew she was going to tell me the honest truth. And then she came back a month later for her post-procedure check. And she's like, "You changed my life." I'm like, come on, really? You have no idea how much better I am. I'm not sniffing all the time. People don't think, especially in COVID, people think, people sniffing a lot or coughing, because it can cause, one of the things pulmonologists will send these patients to me who have subjective postnasal drainage because they think it's making them cough and hurting their lungs. And they come back and like, yeah, this is amazing. I'm like, all right. For a simple thing, it takes 15 minutes to numb up the nose and about 5 minutes per side to do the treatment. In and out in a half hour, not too bad.
I presume though, the allergic group, I mean, all the usual things that we would do as allergists were done first,
Yes,
and these people are still.
and they're still having the postnasal drainage. And I tell patients, look, you still are gonna have your allergies. Go do your allergy shots or drops. But this is going to help that particular symptom. So postnasal drainage, but also congestion. And then some unpublished research will show that soon that it helps eustachian tube dysfunction as well.
I just said one thing, I think we would object to: go get your allergy shots or drops. We don't do drops.
No drops anymore, or drops out of favor?
I don't think they've ever been.
Well,
in
there's
favor.
sublingual tablets that are
Yeah,
FDA approved,
but
but the multi-allergen nasal immunotherapy is off-label, and there are some board certified allergists doing it, but it's not in this practice.
It's not an academic practice.
So that's probably why insurance doesn't cover it then.
Yeah, it's probably got something.
Private asset research supporting it. Good to know. All right, so these patients do get a stuffy nose for 7 to 14 days. They use saline sprays or irrigations. And then I have them follow up in a couple months just to make sure there's not a crust in the back. Yeah, but again, 1% risk of significant bleeding where they actually have to go back to the OR. So it's not just pop in, pop out. It's like, this is a surgical procedure, even though it's done in clinic and it's short and sweet. There are risks with it. So if you figure out what type of rhinitis they have, try the ipratropium. If, again, another unpublished study, hopefully it'll get published, but it's out of my control right now. If people respond to ipratropium, there's an 80% success rate with the posterior nasal nerve ablation procedure. If they don't respond to ipratropium spray, it's 50-50 chance whether or not they respond. So I always do ipratropium, and then I help guide that for my discussion with them and guiding their expectations. And when we're talking about quality of life things like this, even with sinus surgery, if it's not a really horrific sinus, it's all about expectations ahead of time. All right. So I want to talk a little bit about chronic rhinosinusitis. Any questions though about rhinitis while we're talking about runny noses? Anything you would do different on a patient who came in with this runny nose, you treated their allergies and ipratropium?
But one question I had back on one of your early slides of the types of rhinitis. Can you go back to that slide for a second?
You bet. It's a nice little recap, isn't it? Just can't miss one of these. No, we're almost there. There we go.
So vasomotor rhinitis on the bottom and elderly rhinitis, I've always assumed are the same thing. You actually think that's different?
I think it's different. I think elderly rhinitis is part of vasomotor rhinitis, but the elderly rhinitis, they're specifically not going to have. So let me backtrack. Vasomotor rhinitis, runny nose with exercise, eating hot spicy foods, and changing temperatures quickly. outside cold, inside hot, or vice versa. So that's how I see vasomotor rhinitis being defined, which encompasses gustatory rhinitis, elderly rhinitis. And then there's nothing on here that talks about the hot to cold change temperature rhinitis. So some overlap. And if you had a Venn diagram, you would see an overlap in the middle of that. It'd be a nice way of showing it. All right. I'm hesitant to hit the escape button and lose our connection, so to select the slide, so I'm just gonna go like this. Has anybody had a patient that has gone to an ENT for posterior nasal nerve ablation? That you know of? Okay.
A lot of pediatricians.
You guys is.
A lot of pediatricians?
No, in the room.
Oh, okay.
The second year, do you get to spend any time if you want with the EMTs?
We could, but yeah, we had to coordinate it. So yeah, neither of us had.
I think it's, back when I was at the U and Drew was there, you guys spent a month with me. And it was great for me as well. I learned a lot from the fellows. Puyallup's only 33 miles away from UW Medical Center. And I'm happy to have you anytime, That's right. Oh, I checked several times. Yeah, I mean, just, here's my email, just email me. You can come down, spend a half day in clinic with me. And I think it's really important to see, I even had the fellows driving the endoscope at one, after you spend a few days with, so. But come down for a half day and just get an idea of what we do. I think that's important. Or with the ENTs at the UW, there's 3 of them right now. They're all fantastic guys. I really respect them and appreciate them. You had a question?
Yes, so there's a lot of discussion about capsaicin nasal spray use in these patients. Does that predict response to this procedure, or do you have any experience using that in your patients?
I've had patients use the capsaicin. I've had people who swear by it, and I've never recommended it. I haven't looked at the research once, and I know it hasn't been looked at with this. We'll do that second. So I don't know the answer to that. Let's see. Saying multiple patients to use since it is not easy to get this procedure. Well, thanks. Who is that? T.
Probably Paul.
I'm thinking Paul.
Yeah.
Hi, Paul. Good to see you. Kind of can't see you, but thanks for the patience. So I don't know. Have you used capsaicin in your patients?
I've had one patient attempt it and he couldn't tolerate the initial discomfort from it. And then I guess my other question is what's the long-term outcomes for these patients? Like 1 year, 2 years, 5 years, or any data on that?
Yeah, so now on the initial RF device, it's called Rhinair. We have 4-year data on that. And for the responders, it continues to work out to 4 years. I have retreated probably 1% of the patients I've treated previously. And we kind of would expect that, a lot of nerves do regenerate. And patients who have a good response for a year or two, again, just less than a handful will come back and say, hey, can you do it again? And it's usually the patients that I did early on. So the Clarifix cryotherapy patients. And I said, yes, but I'm not going to use the cryotherapy again. We're going to do something different.
And you said there was a portion of allergic rhinitis patients that responded to this therapy, is that correct?
Yeah, it's the same percentage as with allergic and non-allergic, so roughly 80%.
Do you know if anyone, neuroimmunology is all the rage these days. Do you know if anyone's looked at like the nasal smears in those patients or any kind of inflammatory profile or cytokine profile to see if there's any changes?
I've been involved with several of the studies that have been published and unpublished, and we're not looking at smears. What would you look for? What would be the?
I would just be curious if there's a reduction in eosinophils, although that's not a very specific finding. And then, I worked with Larry Borish at UVA for a little bit, and we always talked about local IG production in the nose. And so I was just curious, if there was a pre and post to see, is there an impact on the inflammatory cascade in these patients?
Yeah, those are 2 great thoughts.
While you bring it up, the eosinophils and nasal drainage, when you move to Northwest, you should set that up. I mean, it's a simple test that, we least my feeling always was those were not gonna diagnose eosinophilic non-allergic rhinitis unless we can just simply look for eosinophils.
Yeah, and I would say, I totally agree with that, and just from a political history thing, I mean, historically with allergists and ENT, there's a continuum of people that do the same thing on every patient. In my experience, non-allergic rhinitis especially was the biggest challenge in our practice. I mean, it's a lot easier to treat severe asthma in my hands. And so when there's people like Greg doing this and Peter Huang, who is an academic guy at Stanford that was first author on one of the earlier studies you showed. I mean, to me, it's a blind spot in our own curriculum to not be, including a broader array of things, especially now that it's basically non-invasive, that there's not much downside.
So for those online, there's been a discussion about eosinophils and whether or not this changes the eosinophil or IgG profile in the nose. And then also just a gap in the allergist knowledge base, but I'll also say a huge gap in the ENT's knowledge base. So most general community-based ENTs are not doing this procedure, the majority still. And part of it is you have to be very comfortable working in the nose on an awake patient. This is super, super easy to do if someone's under anesthesia and you're doing something else. But it takes a different skill set to numb up the nose properly and then to have a nice conversation with the patient while you're sticking not only an endoscope, but an instrument in their nose, same nostril at the same time. There's just not a lot of space. So yeah, that's why many, like I said, generally it's a rhinologist that will be doing this. Yeah. But interesting. So maybe in the next study that comes about, I mean, it's just money to measure, do smears for eosinophils. Yeah, be curious to see. Okay, so this isn't a long discussion, but this is just an update from my perspective of. Here we go. Okay, so recently we updated our international consensus statements on allergy. For allergy and rhinology, but on rhinosinusitis back in 2021, and the previous version was 2016, sorry, it's 739 pages. And there's, I don't know, probably 120 authors. And this giant international consortium of friends and rhinologists and ENTs and allergists and pulmonologists who reviewed everything. And we call it the international consensus statement. The European position, they have a different statement. But one of the key things that I just want to reiterate, and I'm going to very much truncate this talk. I'll talk more about this when we have the forum in October. Correct. So to diagnose chronic sinusitis, this is it's like step one. Patients have to have 12 weeks of symptoms. And trust me, insurance companies are looking for the timing in my notes, especially if we're putting in pre-authorization for surgery. 12 weeks of discharge, obstruction, decreased sense of smell, facial pain or pressure, or cough if they're in pediatric patients. And then for us, they must have objective evidence, either endoscopic evidence, so you look in the nose, which we always do first to look for signs of polyps or purulence or significant edema. If we see that, then we can do a treatment first, medical therapy first, followed by a post-treatment CT scan. If I look in the nose and I see a perfectly healthy sinus, I'm still not going to treat them because I want to make sure I'm making the proper diagnosis. I'm going to get a pre-treatment CT scan. And so sometimes patients have to come back. We do have a CT scanner in our office, but a lot of insurance companies require pre-authorization. If they live far away, we'll do a scan close to their home, they ship it down to me, and then we do a video telemedicine. It's quite easy. But we got to make the proper diagnosis because 20% of patients with chronic rhinosinusitis symptoms have no sinusitis, totally normal CT scan. So you're treating either allergic rhinitis, non-allergic rhinitis, or a facial pain disorder. So the summary for medical management of uncomplicated chronic sinusitis without nasal polyps, this is what we do. 2 to 3 weeks of an oral antibiotic, usually a macrolide, like azithromycin or clarithromycin or doxycycline. Not Augmentin, not Bactrim, not Cipro, And we use macrolides or doxycycline because independently they have significant anti-inflammatory properties. And sinusitis is primarily an inflammatory problem. 15 years ago, we thought it was an infectious problem, but no, it's the other way around. So that's why we use those two classes of medications. 4 weeks of nasal steroid sprays or steroid irrigations. Budesonide is the one that came out first. Mometasone is a better steroid. Now the compounding pharmacies will package that with a salt packet. And that's more lipophilic than budesonide, which is hydrophilic. So the mometasone will stick to the sinus tissue better. The problem is, if someone has not had sinus surgery, almost none of that irrigation fluid gets into the sinus. So if you have your non-sinus surgery patients irrigate, they're going to irrigate, they're going to feel better. It's better than doing nothing, and they should do irrigations. The research shows patients who irrigate with a sinus infection recover their infection 3 days faster than patients who use a saline spray bottle. That's the research we have for saline irrigations. That's it. Okay. But if you have a patient who's had sinus surgery irrigate, they're going to tell you an hour or 2 or 3 or 4 hours later, saline comes out of their nose when they bend over. That doesn't happen if you haven't had sinus surgery. And that just shows you that the salt water doesn't get into the sinuses. And then the cadaver studies that color dye the saline and irrigate cadaver heads that have not had sinus surgery also show that the irrigation does not get into the sinuses. So sometimes we do surgery just to facilitate topical delivery of medication. And that can be for a lot of different reasons. People who have common variable immune deficiency, and we want to avoid treating them with oral antibiotics every single time they get an infection. Sometimes we'll do sinus surgery to minimize that. They still get infections, but then we can treat them with topical antibiotics added to the irrigations. And it works okay, just okay. It's not fantastic, but it does work in several patients. If they have nasal polyps, we'll add a prednisone taper. This is the regimen I use, and many rhinologists use 30 milligrams for 4 days, 20 for 4, and then 10 for 4. And it's a nice low dose that at this dose, there has not been a reported litigation against the provider. Okay, doesn't mean can't be a complication, but there hasn't been a litigation yet.
Do you think there's a role for something like Xhance in this situation?
Yeah, great question. The question was, is there a role for Xhance? Xhance is the exhaled delivery of fluticasone propionate. So you stick a little device, you stick one tube in, and just full disclosure, I am on their advisory board. But you put one of the tubes in your mouth, the other tube up your nostril, and while you pump it, you blow at the same time, and that delivers this powder deeper into the sinuses. It is the only drug right now FDA approved for chronic rhinosinusitis without nasal polyps. It just got FDA approval 2 weeks ago. Yeah, it's interesting.
What's
The only
it called
drug,
again?
Xhance, spelled XHANCE, and you can go to Xhance. I don't want to sound like a commercial. You can go to xhance.com, and there's a lot of information there. That was awful. You set me up for that. And so it's expensive, and it's expensive, but it works. It is a non-surgical alternative for not only CRS with nasal polyps, but CRS now without nasal polyps. If the polyps are huge, meaning if you look in the nose with the nasal speculum in your otoscope and you see a polyp, those polyps are too big for any topical therapy. If you look in the nose and maybe you think you see a polyp, but it might be the middle turbinate, can't really tell, those patients are probably pretty good for Xhance. It costs anywhere from $400 to $500 per month. Yeah, and it's a little bit of a challenge to get insurance to cover it, but they have this portal where there's a third party, you fill out this online form, you send it off, and then the third party does the negotiations and figures it out. But if they have commercial insurance, so no government insurance, but if there's commercial insurance, there is a patient support program where it's, I think, maxed out at $50 per month. So a lot of patients will do that. Unfortunately, if they have Medicare, Medicaid, or even TRICARE, they don't have that patient support program for those.
Do you think this is superior to like nasal steroid irrigations, the Xhance?
Xhance has not been studied against nasal steroid irrigations yet. I know it's superior to a nasal steroid spray because all the patients enrolled in the enhanced trials had to fail nasal steroid sprays prior to going into the studies. I will, because of the expense, my general plan is to use mometasone irrigations, usually after surgery, rather than Xhance. If the patients are failing on mometasone irrigations, meaning if the polyps are starting to come back, then I'll put them on Xhance. So anecdotally, that means that I feel Xhance can work a little bit better. I think one of the reasons it works a little bit better is compliance is so much better. You know, asking a patient to irrigate with mometasone twice a day is asking a lot of people, especially long-term for polyp control. But asking them just to spend 5 seconds using Xhance twice a day isn't too bad. Side effects of Xhance, same thing as side effects of all nasal steroid sprays, epistaxis. At the entry dose of Xhance, the bloody nose was 3%. If you go up to that's 1 spray to both sides twice a day. If you go up to 2 sprays to both sides twice a day, the incidence of epistaxis goes up to 9%.
Can I ask you the difference between budesonide and mometasone? I've always used budesonide, and I always thought it was because it was water soluble that we could use it. And you just mentioned mometasone is less so. So I presume it's not miscible with saline.
It still gets into solution. The reason we started with budesonide was Pulmicort. It's all we had.
Yeah.
Right, and you could often get it. One, it was available 12 years ago, 15 years ago when we started using it. And second, insurance would often cover it, especially if they had asthma. So no insurance covers the compounded version of mometasone. But it is, because it's lipophilic and sticks to sinus tissue, we feel that it works better. It's also in the little implants like Sinuva or Propel. These are little steroid releasing implants that an ENT can put in the nose after sinus surgery. That's coated with mometasone. The reason they chose mometasone is because it gets absorbed by the tissue better. All right.
I have a question. I have a question about the bleeding.
Yes.
You say that happens 3 weeks later after the ablation. How severe can that get?
Yeah, so in 1% of people who were looked at in a retrospective review, they had to go back to the OR. So that's pretty significant. Meaning they went to the ER, they had a rhino rocket, a balloon placed in their nose, and that didn't work, and then they had to go to the operating room.
This is the summary of 739 pages.
This is a summary of 739 pages. Yeah. Don't use antifungals. That's the other thing. You know, unless they have invasive fungal sinus disease. The other thing, so when we're talking about uncomplicated sinus surgery, prior to considering surgery, obviously we need a sinus CT scan. Ideally, it's a post-treatment CT scan. As I mentioned earlier, if you're not sure about the diagnosis, just get the scan. Especially if they don't respond to a single course of antibiotics, get a CT scan. If you're going to get a CT scan, please get a CT maxillofacial, CT max, not a CT sinus. And the reason is CT sinus, it's the same amount of radiation, but CT maxillofacial stores many more slices, at 0.6 to 1 millimeter slices versus CT sinus is 2.5 to 3 millimeters. Thinking ahead, if your friendly ENT is someday going to do sinus surgery on that patient, we need a CT max phase to use with our image guidance. That is a nice machine we use during surgery to track the tip of our instruments to allow us to do a safer, more thorough sinus surgery. So that's why sometimes you'll see ENTs get a different CT scan rather than CT sinus. So then the question is biologics in our last couple minutes. When do you use those? And this, again, it's so funny, like an ENT, 32 patients, like, yeah, that's a big study, right? So we're a little warped, but this one was a 12-month retrospective review. 16 patients were on a biologic prior to sinus surgery versus 16 patients were just on the biologic and did not have surgery. So the surgery was performed 33 days after starting the biologic, and the follow-up was 12 months later. And what they showed was the polyp score for biologics plus surgery went from 4.73, again, max was 5, 6, max was 6, down to 0.09. So the polyps were essentially gone. In the controls who just had the biologics, the scores decreased from 5.2 down to 3.8. So a huge difference when we operate and we do, you know, what some people say, IL-4 ectomies, IL-5 ectomies, IL-13 ectomies, eosinophil ectomies. We take out the polyps and we get down to a healthier baseline, but that still doesn't fix the underlying problem. The reason we take out the polyps is to allow the topical therapies to work, and then we know that biologics work better. If I have a patient, especially with AERD, one of the things I learned from this group a couple years ago, where you had someone talking about biologics or aspirin desensitization, and very few. Is anybody still doing aspirin desensitization? But the number, like 5 years ago, everybody would raise their hand. Yeah, and so it's pretty uncommon now, and that was eye-opening for me, because I kept referring patients out for aspirin desensitization, and then we come back on one of the biologics. But this, in these patients who you send to a rhinologist, if I get a patient, they're already on a biologic, maybe because they have uncontrolled asthma and polyps, I know with very high certainty that surgery is going to be very successful in that patient. It's just like, oh, sweet, they're already on a biologic. If they're not on a biologic, like, okay, well, there's a good chance you're not going to need to be on a biologic. Let's see how you do with sinus surgery and topical steroid therapy. And if you start to fail, we'll try XHANCE for a couple months. If you're still failing, meaning if I see the polyps starting to come back 6 months, 12 months after surgery, then I'm going to put them on a biologic, or ask if they came from an allergist, I'll ask the allergist to put them on a biologic, or a pulmonologist. Do you have a thought, Glenn? What do you think about that? Misguided?
Well, you have more experience, but you know, before we had biologics, the recurrence of polyps, I always thought was very high. And so I would think, why wouldn't you want to intervene with a biologic shortly after the surgery? Because then you know you're going to be down to 0.09 and basically protect them from having to operate again. So intervene with the biologic quicker after you go through the surgery.
Yeah, this is the mental debate we have. When do you put them on the biologic? Do you do it ahead of time, say, might as well do it? Or do you wait and see how they do? Now, I would argue that the difference between how we treated polyp patients in the past, pre-biologics, is it does depend on the type of surgery they've had. And the type of surgery depends on the skill set of the surgeon. Not every surgery is the same, and it is truly important for you all to recognize that. And it doesn't have to be a rhinologist. There are some comprehensive or general ENTs who do great work. But 70% of my surgeries are done on revision sinus surgery patients, patients who other ENTs have already operated on. And in all those patients, they've left, not all, most of the patients, they've left sinuses or cells, we call them, along the orbit and along the skull base, right where the skull base transitions into the frontal sinus, and that's where the polyps tend to grow back. So you just have to do a little bit more thorough sinus surgery. The idea is a wide open floor plan, take down all the little partitions. It's no more risky than doing regular sinus surgery in the right hands, but just a wide open surgery so the topical therapies can get in. If you leave a bunch of these little cells, assuming they're all diseased, don't need to operate on healthy sinuses, but assuming those cells and pockets are diseased, you got to take them out so the topical therapies can then get into the frontal sinuses. And that's the main difference is if a patient does the topical steroids, if they've had good surgery and are controlling their allergies, I would say there's only about a 20 to 30% risk of polyp recurrence. And that's a lot different from how it was 10, 15 years ago, where it's like 80% recurrence because we weren't using the topical steroids. It really has dramatically changed our treatment success. So I don't know what the right answer is with biologics. I'm always happy to operate on patients who are already on it. Again, they're gonna do fantastic. I think it's also reasonable to have a wait and see approach. I think that's where shared decision-making comes in with the patient. And, there's some side effects with biologics, sore joints, red eyes. They're pretty minimal. The cost is something that certainly needs to be considered, though. They're still
And
extremely expensive.
along those lines, is it rule of thumb that like the surgery is equivalent in cost to a year of the biologic or something like that?
Cost effective in the.
Yeah, well,
research
exactly. I
studies,
mean,
meaning that surgery is cheaper, assuming there's no complication.
Okay, that's what the point I was gonna try to.
Yeah.
Clarify, okay.
I always thought most of the polyps started in our ethmoid sinuses. You just said frontal.
It's the transition from the ethmoid to the frontals. So right where frontal sinuses are coming down and start to curve and become the ethmoids, it's always where they grow. And we don't know why. The tissue's been biopsied compared to other areas. It's unknown why that tissue is the.
Can't
In
zap
most
that area.
cases. What's that?
Can't zap that area.
Well, I don't know if I want to.
I know.
A little dicey. Yeah, but that's the issue. So, all of that. So that's the summary. Consider holding off on biologics until after sinus surgery, but certainly not if they have uncontrolled asthma or they need it for their asthma or eczema. And we're always happy to operate on patients who are already on biologics. It's pretty much a home run or at least a triple in the making. Word of the day is the septum. Or sorry, septum, not the septum, just so you get that right. And thanks for the conversations. Happy to stick around for a bit. Oh, there's a question. No, that's still Paul.
It is still him,
He has
but
another
there's another
one.
question.
Oh, no, he just said yes, it's Paul McBride. Hey, Paul. Oh, wait. Can doing a total ethmoidectomy prevent the reformation of polyps, or do you think that combo therapy with biologics and surgery? So yes, I definitely a total ethmoidectomy. If it's truly a total ethmoidectomy and not a partial ethmoidectomy where the surgeon is just poking some holes in the ethmoids. And I know that sounds potentially controversial, but it is, and that's the discussion we have with our ENT colleagues is if you're gonna operate on polyps, you have to do a thorough surgery because all that, it's just decreasing surface area. It's such a simple concept. The less amount of surface area there is, the less amount of inflammatory tissue there is to make polyps, and the better the penetration of the topical steroid solutions.
You mentioned Adelaide a couple of times. Did you study
I did,
in Australia?
yeah.
You
So
don't
that-
sound Australian.
No, you're not gonna get me to do it. No, it was fantastic. They're the nicest people on the planet. It was really fantastic. It completely changed in 6 months. It completely changed how I approach sinus surgery. So, yeah, modern approach.
Any more questions inside the room, outside the room? Thank you for a fantastic presentation. I think it's very valuable for us as non-surgeons to see how you go about this. Really appreciate it.
My pleasure. All right. Well, there's another chat. Well, well, thank you, Angela. Hey, let's leave this up. This is great. I'm gonna beam this to my parents, right? All right, everybody have a good day.